So I wanted to share a quick case study that I've seen a patient myself in the South Surrey clinic. It's concerning a right ankle injury, and I kind of wanted to share with you guys what I did, as well as how I structured the treatments. And I think a lot of you guys will find it interesting, and it'll be a little bit different than what a typical physiotherapist thinks of when it comes to treating. Okay, so when it comes to patient overview, this patient came into me, it was about 3 months ago, but their injury was in 2022. Their primary diagnosis, Pilon fracture. This is quite a devastating injury because, as you can see, this is the talotibial joint is one of the most complex joints in the body. And when you have a break there, and there's so many bones that are involved, so there's a lot of structural damage that's occurred. And as a result of that, obviously the surgery was quite extensive, and so it's not a simple injury to kind of come back from, especially as you're older. So her current status is patient status is a nurse as well. So it's very important to look and see what kind of work this individual is doing as well, whether they're standing, whether they're sitting all day, and it makes a huge difference, especially when it comes to an injury like this. So her current gradual return to work is December 17, 2024. She's doing about 6 hours a day, 3 days a week, January 20th. And I believe that's around the time when I started seeing her. It was about 8 hours, 3 days a week. But she was really struggling to get back to full duties because of ongoing symptoms. And her goal is to get back to 5 days a week. So a little bit about the history. So September 2022, she fell from a height and she fractured her ankle. She also had some post-surgery complications. I don't have any pictures of it, but she had a lot of scarring on the top of her ankle. And then in September 2023, obviously during that time, she did physiotherapy. I wasn't involved in her care. It was another physiotherapist. She said it did go quite well. There we go. Everything went, it was kind of going quite well, but at the same time, there was a bit of a plateau. And then September 2023, she got an X-ray done, and there was some post-traumatic arthritis that's starting to creep up in that joint. And the reason why that is troubling is because with an ankle joint is, like I say, it's very complex. They do sometimes do joint replacements, but it's very complex once again. So and this was very troubling to her because of the fact that she wants to get back to work, and she's already developing this arthritis. And even though she's someone that's in the healthcare field, once again, when you mention arthritis, people kind of freak out, and they're like, what's gonna happen now? Right away they think they can't put weight on it, it's going to stay inflamed for the rest of their life, yada yada yada, right? So, and then January 2024, so she started getting symptoms of crepitus, intermittent ankle seizing. So her ankles would kind of seize just randomly, and that's really terrifying because being on your feet all day, you never know when that's going to happen. And she's just getting ongoing and persistent pain. And then in May 2024, the ortho consultation, because she thought there was something wrong with the hardware. And then upon ortho consultation, hardware was fine. There was definitely some swelling in certain tendons and things like that. And then and then she did mention to the ortho about ankle seizing. And then ortho kind of chalked it down that at this point it's chronic pain that's set in. And there's really not much else that the ortho can do for her. So ortho advised chronic pain management, so probably injections and the whole shebang. Any questions so far? So her current symptoms, persistent pain and swelling in the inner ankle, and she did say, based on imaging, her posterior tibialis tendonitis is set in. Joint seizing and numbness on top of the foot. Pain levels were 4 to 7 out of 10 when weight bearing, so it's quite a bit. And having to do that all day long, I mean, it gets exhausting. Stress level at work, was moderate due to ongoing pain. Otherwise, her work's very accommodating. So these are some of the main things. So some of the things that I look at, for example, this numbness in top of the foot. Right away, I kind of associate that, whenever someone has numbness on top of the foot, yes, it can be nerve related, but also there could be some trigger points that are causing that numbness. Same thing with joint seizing. All of these things are symptoms that there's some trigger points that are occurring. So objective findings of the ankle assessment, her range of motions was around 80 to 85% of normal. There was some cracking in the joint. Why that cracking is occurring, that's the million-dollar question. It's very hard to say whether could be the hardware, it could be the tendons that are causing the cracking. But patient right away associates that with arthritis. Right away when they think cracking in the joint, it's arthritis, then they're not very happy with that. Her strength, eversion strength, is around 4 out of 5. Single leg heel raise was minimal pain and it's performable. As you can see with my objective findings, it's one of those things where us as physiotherapists, we're so hell bent on making sure there's enough plantar flexion, dorsiflexion, eversion, but we kind of miss the point of, hey, how can we treat the pain that's occurring with this patient, rather than just being so hell bent making sure that she has an adequate amount of dorsiflexion in her ankle, and if she doesn't, that's why she's having the pain. So with this type of patient, especially a patient that's been suffering since 2022, almost 3 years, you got to look at the trigger points. So meaning you got to look at the muscles that are around that joint and which could be causing for most of the symptoms that are occurring within, whether it's numbness, joint seizing, ongoing achy pain. These are all signs that there's some type of trigger points that are causing those symptoms. So rather than going, and getting her to do all this physio-related stuff, I right away, a big part of my assessment, especially when it comes to chronic pain patients, is looking at the trigger points. Identifying each and single one of the muscles that are associated with this joint, and how are those muscles when I'm palpating them and pressing them. Considering that she is getting numbness on top of the foot, a good chance that tibialis anterior could be the problem. Because you can see that tibialis anterior goes right across that ankle joint, and she has a big scar here as well from poor healing. I think she had some bacterial infection. So all that stuff can impact this muscle, and that muscle not to be a happy camper. The same thing, extensor digitorum, extensor hallucis longus. See, these are all muscles that we need to evaluate, especially with chronic pain patients, because when people come in to see you for physiotherapy, a lot of times, especially when they come and see me, they've seen another one or two physiotherapists. They've gotten all the exercise, they've gotten all the strengthening bit, but a lot of the time, the physiotherapists overlook this aspect. It's figuring out why is the pain, because the pain a lot of times physiotherapists associated with because of the fact that the ankle joint is weak. Well, what the hell does that mean? Yes, the joint is weak, but the reason why that weakness is sometimes occurring is not necessarily because the muscle itself is weak, but there's inflammation within that muscle. Like same thing with peroneus longus. So all these muscles, what I did was I spent a lot of times mapping out which muscles are the problem around this joint. Because all these muscles, they cross that ankle joint. So whenever that muscle crosses the ankle joint, I need to investigate and see what's going on. So all of these guys I looked at and I try to figure out what's going on. Another one of my big objective findings, I didn't spend a ton of time looking at the objective findings of the ankle itself, but I did want to look and see what's going on with her hip and her gait analysis. And the reason why I wanted to do that is because of the fact that this patient as a nurse spends all of her time standing on concrete floor. And as a result of that, the standing and how she behaves in a single leg standing position really gives me a good idea how much stress there is on that ankle and how the muscles above that ankle are performing when she's doing a single leg stance. So I had her walking, and I'll show you guys a video, and I did do a sideline hip strengthening test. So basically like a sideline test hip abduction, and she was about a 4 out of 5 compared to the left side, so a little bit of weakness. I also did a Faber test as well, meaning that one where you put the put someone's foot over their opposite leg, and you kind of let it fall and see how far off that knee is off the plinth. So her right hip's about 3/5 distance, so about height wise 3/5 distance from the ground, whereas the left one's about 2. And often that indicates that there's some sort of restriction in. The reason why there's a difference is potentially because there's some sort of an overuse of certain muscles versus other muscles. And also, I'm looking to see whether there's any compensatory patterns. So when I had this patient standing on her single leg, once again, this is a patient that's come in with ankle pain. But this is one of the most important things, is looking to see how. So this is her left side. So I want to see how she's loading where her center of mass is when she's standing on that left leg. What's going on? How far that hip is shifting out. How well she's loading that through that ankle joint. Versus here, you can see that she's shifting out a little bit further. That hip is going a little bit further. She is also rotating a little bit. And you can see that Q angle is a little bit higher on this side, which indicates that she's probably using her groin muscles to stabilize when she's standing on that right leg. And also another thing is you can see most of her weight on the left side. You can see the weight's distributed nicely throughout the foot, whereas on here, that most of that weight is sitting where? It's sitting on the outside of the foot. And as soon as that outside of the weight sitting on the outside of the foot, that automatically triggers the lateral chain muscles to be engaged a lot more than the actual glute muscles to stabilize this person as she's standing in that one leg. Because this is the key, because if these muscles within the right hip aren't working to stabilize, then guess what? All these other guys have to do the work. And as a result of that, these guys will suffer. They'll do more. Her legs are going to be more achy because these muscles have to do more work because their hip muscles aren't firing. Why her hip muscles aren't firing is probably because she's created that antalgic gait. When she first started to walk, the previous physiotherapist, he was so hell-bent on making sure that her ankle's strong, making sure that she's doing single leg heel raises. But also you got to look and see how the quality of that heel raise is. Whether she's pushing, she's pushing more with her fourth and fifth digit rather than, going through her first toe. These are all little things that I feel like in a lot of time in our rehab setting we miss, but these are the key structural guidelines to basically make sure that we get that neuromuscular pattern to work properly. Let's see if this works. So what it is, what I do with a lot of my patients that come in, I do a lot of this visual stuff. So I want to see how well what I do is I break things down and I see how she is loading on that right leg, because single leg stance versus a dynamic stance is totally different. So what I did was I took screenshots. I took screenshots as to how well she is in that moment of time, and this is the most important time. This is the most important moment in time when the left hip and the right hip really come into play as to how well they're stabilizing that whole lower chain. So taking these snapshots really gives you a good idea as to what's going on. You can see on the left side, that hip is stabilizing pretty good. Whereas on the right side, you can see as soon as she's loading, as soon as this left leg is off, what's going to happen is that this hip is kicking out. And as a result of that, it's inhibiting the work of the hips, of the glute muscles, the stabilizers, the glute med. As soon as that glute med is in a lengthened position, it's not going to be able to contract. So what happens then? Then what happens, that patient, guess what, stabilizes with their groin muscles as well as uses the lateral chain extensively. So they use their IT band, their vastus lateralis, their fibularis longus, their tibialis anterior. All of those muscles get used a lot more because these guys are in a lengthened position at the most important part of their gait. So this part is very, very important to catch and figure out. Because with this patient, the bigger key when it comes to strengthening exercise is to focus on the hip and making sure that her brain is aware of how she should be loading that hip in this instance, rather than focusing, making sure that her ankle dorsiflexion is strong enough, getting her to do band exercises to improve the strength of her tibialis anterior, because we're kind of past that stage, because I'm sure the previous physiotherapist did that, but I'm not very sure that he did something like this. So also what I've identified is I also go into the hip, because sometimes those muscles can be also inhibited because there's trigger points within that muscle as well. And I palpate each and single one of these muscles. For example, this gluteus minimus. When I palpated her gluteus minimus, she was shooting pain right down the side. It's a classic gluteal minimus sign that's shooting right down into the knee or even into the foot. Gluteus medius, same thing. The groin muscles, I checked all of those guys, as well as the vastus lateralis, because vastus lateralis is getting overused. So my treatment approach with the first session, I was not worried about what kind of exercise she's doing or what kind of exercise to take home, whether certain things are weak, because over time this patient has heard from so many clinicians how weak she is and how she needs to strengthen, how she needs to get stronger, and that's going to be her holy grail, and that's going to get her out of pain. But a lot of time that's not the case. So what I did first couple of sessions, just focus on releasing the trigger points and starting from the hip down, and make my way. Spend each of the trigger points. Spend a few minutes. Introduction to IMS for trigger points. So in addition to doing hands-on therapy, I've also tried to introduce some IMS and shockwave. I definitely introduced the first time the shockwave machine because it's a great way of getting into those trigger points. And at the end of the session, because I did do a lot of soft tissue, guess what? I need to tape this person, because when they walk out, there's a good chance they're going to be more sore than when they came in. So what you got to do is try to do whatever you can to make sure that that experience after that patient's walked out is as painless as possible. So taping is great. So I just taped her ankle, because I did a lot of trigger points around the hip as well as the ankle. And then introducing the patient to a lacrosse ball. Just getting rid of those trigger points at first, getting the pain down, because once you get that pain down, then the patient's like, well, this guy knows what he's doing. He's able to actually get me better. Then you start doing a little bit more of the strengthening and exercise. But first few sessions, this patient probably has booklets of exercises that she's been given to strengthen that area. And you don't necessarily need to work on that part first few sessions. And, I did a couple of sessions of IMS. The patient did not like IMS. And you cannot force people to do things if they don't like them. So my sessions, and I've seen her probably about 7-8 times now, it's been mostly shockwave and hands-on therapy. Introduction, also one big thing, introduction into medical grade compression socks. Because if you can imagine the amount of damage that's happened, the lymphatic damage that's happened within that ankle, so that fluid coming back from that ankle into the rest of the body is going to be compromised. So whatever you can do, and compression socks are great because they reduce the swelling in that area. Guess what happens when you reduce the swelling in that area? You are able to, once you reduce the swelling in that area, that inflammation is going to be a lot less. So introducing anyone that's standing for prolonged periods, and especially having, calf pain, having any sort of ankle pain, having any Achilles tendonitis, all of that stuff, the compression socks work well because of the fact that they're able to take the fluids out a lot better, and as a result of that lead to overall less inflammation, less trigger points within those muscles, which a lot of the time are the ones that are causing the symptoms. And then, it's always good to outline a plan with the patient. Hands-on therapy, I usually tell people within 4 to 6 sessions of the hands-on work, you should know whether this is working. And usually within 4 sessions, people are like, well, I've gotten a lot better. And what I do is I usually start to progress slowly with strengthening exercises. And what do you guys think would be my first go-to when it comes to exercise? Like, what kind of exercise would I prescribe this person at first, strengthening wise, based on what I talked about so far? Anyone?
Strengthening the glutes.
Yeah, exactly. Strengthening the glutes. So how would I strengthen the glutes, Parm?
You can do static exercises, kinesiology, dead bugs, resistance bands training. Well, I think Pilates is another thing too. We have a reformer, right? So just getting the whole functional chain to kind of activate, because I think a lot of it is the chain's not working correctly. Then
Yeah. So the chain's not working correctly, but at the same time, if you're doing all those exercises, she's already doing yoga and Pilates. But one of the problems I find, especially with a patient like this that's had chronic pain, is these treatments and these exercises, a lot of times that they're doing, they're very complicated on a movement pattern level. What I mean by movement pattern level is, let's say when she's doing yoga, she's exercising, doing all the exercises, but she's not properly actually engaging the glutes in a functional position. So one of the number one exercises I like to start with, just getting the person to be able to engage the muscles with simple exercises. So like a clamshell exercise, just for her to be able to feel how to engage these glutes is a great way to start. So just clamshell is very controlled. It's not functional, but it's a very controlled exercise, and it's going to give her success to be able to engage those muscles. And another thing I do next time, what I'll do is I'll probably put exercise videos that I send to patients, is hip setting exercise. So I make it simple, and I make it so that this patient's brain is able to easily achieve the pattern that I want them to achieve. So I want them to start getting better at that, because a lot of times it's not that the muscle itself is weak, is that the joint in space, where we put that joint in space. For example, when you put a joint in space here, it's able to successfully engage, the brain's automatically going to be able to engage this glute med. But when this glute med when the joint's in space like this, that glute med's not going to be able to successfully going to be engaged. And as a result of that, what's going to happen is she's going to just have the same neuromuscular pattern. So what we got to do is simplify things down, and I often tell patients, there's no point in me giving you a book to read when you can't even write. So we go simple exercises where they're going to be able to achieve proper engagement of the glute muscle in standing. So I often just get them standing, holding on to something, and getting them into a position where they're shifted, where their hip is kind of stand over the knee, over the ankle, and they're able to successfully, the brain's going to be like, okay, well, now I feel that glute firing. So start with simple and effective exercises, and ideally I want them to be able to fire the glute muscle while at the same time firing the VMO, because when that glute and VMO fire together, they stabilize the femur. So ideally, a successful exercise would be her standing, holding onto a bar, getting her into such a position where she's a little bit more aligned, and doing this at home, even holding it for 30 seconds. And then in addition to that, doing clamshell exercises. I still encourage patients, go and do your yoga, go and do your Pilates. It's fine. But when it comes to rehabilitation exercises, we need to take another approach. And with these rehabilitation exercises, I tell them, it's going to take about 6 months of you trying to get into this pattern to be able to, subconsciously start doing it. But it takes a little bit of time. So also I sent her for R&T, where Gervier worked on low back and all the affected muscles. He worked obviously reducing trigger points, decreasing hypertonicity, because with this chronic pain, everything changes. So it's not just the ankle, it's not just the foot, and that's why I like to send him for massage therapy, for acupuncture, to work on other areas as well. Uh, so always when it comes to these chronic pain patients, take the time to do a comprehensive assessment. See what kind of therapy they've done before. I often ask what did the physio do, what kind of outcomes you got, what were the issues, and then always try to involve multidisciplinary care. And as physiotherapists, we are so gung-ho on getting people doing exercises. But once again, if they're in a faulty biomechanical pattern, which probably they are because they've come to see you because of some sort of pain, then what you got to do is you got to slowly work on changing that. And you have to explain to patients that it takes time. So there's a time and a place for exercises. Most patients come in and see you when they're in pain. And it's often a case of overuse of certain muscles rather than underuse. If they want to get stronger, people usually go to see a personal trainer. They don't come to a physiotherapist to necessarily get stronger. What you got to do is you have to identify which muscles are being overused in this pattern, which muscles are being underused. In this case, underused muscles, gluteus medius. Overused muscles is the adductors. Same thing as gluteus minimus, underused muscle. Based on her pattern, these guys are probably overused, just based on how she's standing here. So you yourself as a clinician, you have to identify that. And that takes time, and that takes, being actually present with the patient rather than just putting them on a heating pad or a TENS unit and hoping things will go away. And one of the things I often tell people is they come to me and they're often saying, hey, I got a lot of weakness, I'm weak. And you don't want to be the 50th professional telling them how weak they are and their pain is usually coming on because their core is weak, they got to strengthen their ankle joint, which doesn't mean anything. So those are some of the things that you kind of have to think about when you have these chronic pain patients coming in. Overall, patient's progressing well with her gradual return to work. She's back to full duties, 8 hours, and it didn't take 40 physiotherapy sessions. We gotten rid of the numbness and tingling. She has not had seizing of her ankle joint, which was arthritic, and which she attributed the seizing to since we started the physiotherapy sessions. So numbness is not there. There's less swelling in the joint because we are working on reducing the inflammation, in addition to making sure that she's wearing her compression socks. Yes, there's going to be aches and pains at the end of the day, and this is a life-changing injury, but our goal is to try and optimize that as much as we possibly can. And she's also able to get into Pilates and yoga classes. And I'm not going to tell her, hey, don't do those because your biomechanical pattern's not where we want it to be. We want to stop everything until we... No, it's like you still want her to do that, but every single time that patient comes in, you got to try and reinforce that neuromuscular pattern that you kind of want to see. And then over time, the brain's going to pick that up. But it takes time. And she's looking forward to doing hiking, long walks, when the weather gets nicer. And basically, we got a Google review from her. So that tells you how good we've done. You don't need any other crazy outcome measures to be able to assess. You can see whether, like I say, it takes 4 to 6 sessions for those patients to figure out whether they're getting better. Now, any other questions? Have you guys had patients similar to this? What kind of approach did you take? What what can you take away from today's case study that you're like, oh man, okay, next time I need to do this. Like, what are some of the things that you normally don't do that you've seen in this uh, case study? Okay, and did you guys learn anything today? What are some of the things to take home?
Sorry, I can add something.
Yeah.
I think just focusing on the bigger picture rather than whatever the patient's actually coming in with. Like you said, other physiotherapists might have just focused more on the ankle and just those strengthening exercises, but the problem might have been coming from like the hip as well. So just trying to focus on other things as well, and just provide more information to the patient about other things that might be happening and contributing to the problem as well.
Yeah, exactly.
Yeah.
And it's often complex. It's not a simple.
Yeah.
This is not a simple case where you can just be like, okay, well, just go and do these exercises and it'll get stronger. But it doesn't work that way, especially when they come and see us.
I agree, guys. And also a great informative presentation. I think a lot of people now are trained to examine the area where there's pain. For example, I had a patient this week, and she's seen every neurologist specialist, and pretty much last place she came to was us, and she had a hip thing going on where actual return it was actually coming from her shoulder and her back after examination. So yeah, I examined the kinetic chains. I think that's the lesson that I learned today after this presentation is don't just always look at the area where they're pointing at. We all already know that. They already heard that 1,000 times. Examine the rest of the joints around the area surrounding them and see how they are, and then make an accurate diagnosis of that. So thanks for the presentation, Milan.
Yeah, and what you got to do is utilize the phones. You have a phone, take a picture how they're standing, take a picture how they're walking. If they're an athlete, take a picture of how they're jumping in one spot, because essentially that's what running is about. But examine, especially for lower kinetic chain injuries, whether it's back or hip pain, you have to examine and see what's going on when they're standing on that one leg. Because most of the time, the injuries and these ongoing aches and pains are occurring because they're doing something on that one. Because that's when they're the most vulnerable to break down with when it comes to some when they're standing on their both feet doing a squat. It's when they're doing a single leg stance as the other leg is propelling forward. So always look and see how they're behaving in their most vulnerable position, because that will give you a clue as to how to tackle that problem. And I had two patients this week come in for they're having hand pain. They've been to a hand therapist, they've been to a hand surgeon, and when the hand therapist, and all I did was just look at their forearm, and I'm like, did the hand therapist ever look at your forearm? It's like, no, they just do stuff on like my fingers and my hand. Well, it's like, well, all the muscles coming into your hand, a lot of them are coming from your forearm. And all I did was just some shockwave and some dry needling on the forearm. It's already getting better. And they've done like 50 sessions at a hand therapist clinic, where the hand therapist just focused on that one joint and that one spot, which, I mean, it's just mind-boggling how that even makes sense. And someone who specializes as a hand therapist doesn't look at the forearm. So, and that's one of the things with these specialists that they go and see. They're so focused on like whatever they're specialized in. Like Parm says, they go to a specialist for their hip. That's all the guy's going to look at. He's not going to look at the back. He's not going to look at the ankle, the knee, and all that stuff. So that's where your job is to kind of come in and look at all that stuff and see how all that stuff makes sense. Any other questions? Anything else you guys learned?
Yeah, thanks, Milan. I just thought it was a really good reminder that the exercises that we prescribe should translate into functional movements. In terms of recruiting the glutes, I find like doing crab walks really helpful, like banded crab walks, and also coming off a step, like kind of like the hip hikes where you have one leg off the step and one on, and trying to engage the muscles. But yeah, definitely helpful to be reminded to look at those functional movements when we're prescribing exercises.
Yeah, awesome, Jennifer. Yeah, so those are all great exercises to recruit those muscles, but you still want to see how that patient's recruiting that muscle during their most important exercise, which is walking. They can do all the clamshells in the world, but if their brain is still so stuck on that pattern where they're every time they stand on that leg, that hip is shifting laterally, the contralateral hip is there's quite a bit of a Trendelenburg. Well, she can do all the exercise in the world, but it's not going to fix that. So you kind of want to do those in combination. And Jen's exercises are great, and they're something to kind of advance on that clamshell exercise. But you still want to always look at it from a gold standard perspective, which is a single leg stance, and see how well they're able to stabilize and engage that glute muscle while they're standing in a single leg position. Good, awesome. And that, if you guys don't have any more questions, thanks for joining in. And I'll throw a few more of these on. I got a bunch of case studies I like to do. So whether it's that or specific reads that I do, I'll throw them on. And then, yeah, we're at 10:40, so I think we're good to sign off. Thanks for joining in, guys. Appreciate it.
Thank you. That was great.